Excuse me, you can't do that. The sharp voice of Nurse Patricia Reynolds cut through the ICU like a scalpel as she stepped between the young black doctor and her patient's bedside. I don't know who you think you are, but only attending physicians can adjust these medications. Samantha Carter looked up from the chart she was updating, genuinely surprised to find the 20-year veteran nurse blocking her path with crossed arms and an expression of absolute authority. But what Patricia didn't know was that she had just challenged the chief of cardiothoracic surgery, and her career was about to change forever. St. Mary's Medical Center's intensive care unit represented the pinnacle of critical care medicine in Chicago, a place where life and death decisions were made every hour and only the most skilled medical professionals were trusted to work. The 45-bed unit hummed with controlled urgency, filled with the steady beeping of monitors, the whispered conversations of medical staff, and the quiet determination of people fighting to save lives. Located on the hospital's 8th floor, the ICU served the most critical patients in the region, from trauma victims to post-surgical cases requiring round-the-clock monitoring. It was here that Samantha Carter had arrived at 6 a.m. for what she expected to be routine morning rounds, checking on the post-operative patients from yesterday's complex cardiac procedures. At 32, Samantha was the youngest chief of cardiothoracic surgery in the hospital's 75-year history, a position she'd earned through exceptional skill, groundbreaking research, and surgical outcomes that had made her legendary among her peers. Her journey to this role had been anything but typical. Harvard Medical School summa cum laude, surgical residency at Mayo Clinic, fellowship in advanced cardiac surgery at Cleveland Clinic, and board certifications that placed her among the elite surgeons in the country. But Samantha understood that her youth, gender, and race made some people question her credentials. Despite her office walls lined with awards, published research papers that had revolutionized cardiac surgery techniques, and a success rate that attracted patients from around the world, she'd learned to navigate constant challenges with grace and professionalism, proving herself repeatedly while maintaining the composure that excellent patient care required. This Tuesday morning was particularly demanding in the ICU. 4 patients were recovering from major cardiac surgeries. Samantha had performed the previous day a complex mitral valve repair, a coronary artery bypass, a pediatric congenital heart defect correction, and an emergency aortic aneurysm repair that had lasted 12 hours. Each case required meticulous monitoring, precise medication adjustments, and the kind of detailed attention that could mean the difference between recovery and complication. Nurse Patricia Reynolds had worked in the ICU for 20 years, beginning her career when the medical field operated with stricter hierarchies and clearer boundaries between different roles. At 48, she took immense pride in her experience and knowledge, seeing herself as a guardian of proper protocol who ensured that inexperienced doctors didn't make mistakes that could harm patients. She'd trained countless residents and medical students over the years, teaching them the importance of following established procedures and respecting the chain of command that kept the ICU functioning safely. Patricia had developed what she considered an expert eye for spotting physicians who were exceeding their authority. Young doctors who thought they knew better than hospital policy. When Patricia arrived for her 6 a.m. shift, she began her usual routine of reviewing patient charts, checking medication schedules, and ensuring that all equipment was functioning properly. The ICU operated on precise timing and careful coordination between nurses, doctors, respiratory therapists, and specialists who each played crucial roles in patient care. As Patricia moved through her assigned patients, she noticed a young woman she didn't recognize working at the bedside of Miss Henderson, a 58-year-old post-cardiac surgery patient who was recovering from a complex procedure. The doctor appeared to be adjusting medication dosages and updating treatment protocols, actions that required attending physician authorization according to hospital policy. Patricia's experience told her that this was likely a new resident who didn't understand proper procedures, possibly making changes that could compromise patient safety. She'd seen this scenario countless times: eager young doctors who exceeded their authority, thinking they knew better than established protocols designed to protect patients. Her job was to prevent these mistakes before they could cause harm. "Excuse me," Patricia said as she approached the bedside, her voice carrying the authority of someone accustomed to correcting medical students and residents. "You can't do that." Dr. Samantha Carter looked up from Mrs. Henderson's chart, genuinely confused by the interruption. She'd been adjusting the patient's cardiac medications based on the latest lab results and EKG readings, a routine decision that fell well within her responsibilities as the surgeon who had performed the procedure. "I'm sorry," Samantha replied politely, though she could feel the eyes of other staff members beginning to focus on the interaction. "I don't know who you think you are," Patricia continued, her voice growing louder as she became more confident in her assessment of the situation. "But only attending physicians can adjust these medications. You need to step away from this patient and get proper authorization before making any changes." The words hit Samantha like a slap. She felt every conversation in the ICU pause, every head turn in their direction. This wasn't the first time her authority had been questioned based on her appearance, but the public nature of this challenge was particularly humiliating. "Nurse Reynolds," Samantha said, reading the name tag while maintaining her professional composure. "I understand your concern for proper protocol, but I am the attending physician on this case. I performed Mrs. Henderson's surgery yesterday, and I'm adjusting her medications based on her current condition and lab results." Patricia's expression didn't change. In her experience, residents and medical students often claimed more authority than they actually possessed, especially young women who thought they could intimidate nursing staff with confident attitudes. "I've been working in this ICU for 20 years, Patricia replied firmly, "and I've never seen you before. Hospital policy requires that medication changes be made by authorized attending physicians, and I need to see proper identification and verification before I can allow you to continue." The confrontation was beginning to draw serious attention from other staff members. Dr. Michael Thompson, a senior ICU attending physician, paused his patient rounds to observe the situation. Respiratory therapist Lisa Martinez stopped her equipment check to listen. Even some of the patients' families in nearby rooms were beginning to notice the raised voices. Samantha realized that this situation required immediate resolution, both for the sake of her patient's care and for the professional atmosphere of the ICU. She reached into her white coat and pulled out her hospital identification badge, which clearly displayed her name, photo, and title. "Dr. Samantha Carter, Chief of Cardiothoracic Surgery." "Here's my identification," Samantha said calmly, handing Patricia the badge. "As I mentioned, I'm Dr. Carter, Chief of Cardiothoracic Surgery. Mrs. Henderson is my patient, and I'm providing the post-operative care that her condition requires." Patricia examined the badge, her confidence beginning to waver as she processed what she was seeing. The identification was clearly authentic, bearing all the proper hospital seals and security features, but she struggled to reconcile the young woman standing before her with her mental image of what a chief of surgery should look like. "This says you're the Chief of Cardiothoracic Surgery," Patricia said, her voice losing some of its authority as doubt crept in. "That's correct," Samantha replied patiently. "I've been Chief of Cardiothoracic Surgery here for 2 years. I performed Miss Henderson's mitral valve repair yesterday, along with the bypass surgery in bed 12, the pediatric repair in bed 8, and the emergency aortic surgery in bed 15. All 4 patients are under my direct care." Michael Thompson approached the group, recognizing that the situation required senior intervention. He'd worked with Samantha for 3 years and had nothing but respect for her surgical skills and leadership. "Is there a problem here?" Thompson asked, though he'd overheard enough of the conversation to understand the issue. "Dr. Thompson," Patricia said, clearly flustered, "this person claims to be the Chief of Cardiothoracic Surgery, but I've never seen her before, and she looks too young to hold that position. I was trying to ensure that proper protocols were being followed." Thompson looked between Patricia and Samantha, understanding immediately what had occurred. This wasn't the first time he'd witnessed someone challenge Samantha's authority based on assumptions about her age, gender, or race. "Nurse Reynolds," Thompson said firmly, "this is indeed Dr. Samantha Carter, our Chief of Cardiothoracic Surgery. She's one of the most skilled surgeons I've ever worked with, and these patients are absolutely under her care." In fact, she just completed a groundbreaking pediatric heart surgery yesterday that will likely be published in medical journals. Patricia felt her face flush with embarrassment as the reality of her mistake became clear. She'd challenged the hospital's chief of cardiothoracic surgery, questioning her authority and competence based on assumptions about her appearance and age. "Dr. Carter," Patricia said quietly, her voice barely above a whisper. I apologize. I didn't read." Samantha could see the genuine distress in Patricia's expression, and despite her frustration with the situation, she recognized an opportunity for education rather than humiliation. The ICU was a high-stress environment where clear communication and mutual respect were essential for patient safety. "Nurse Reynolds," Samantha said, her voice remaining calm and professional, "I understand that you were trying to protect your patient and ensure proper protocols were followed. That's commendable, and it's exactly the kind of vigilance we need in the ICU." She paused, choosing her words carefully. "However, I think this situation highlights the importance of verifying information before making assumptions. In the future, if you have questions about a physician's credentials or authority, I'd encourage you to check with nursing supervision or simply ask to see identification rather than making public challenges that could compromise patient care." The ICU had gone completely silent. Other nurses, doctors, and staff members had gathered at a respectful distance, all witnessing this teachable moment. Some looked embarrassed, others thoughtful, but everyone understood the significance of what was happening. Thompson observed the interaction with approval, impressed by Samantha's handling of what could have become a much more volatile situation. Her response demonstrated the leadership qualities that had made her successful as chief of surgery: the ability to educate rather than humiliate, to focus on solutions rather than blame. "Carter," Thompson said, "would you like me to introduce you to the nursing staff who might not have had the opportunity to meet you during shift changes?" "That's an excellent idea," Samantha replied. "I think it would be beneficial for all of us to have better communication and recognition among team members." Over the next few minutes, Dr. Thompson introduced Samantha to several nurses and support staff members who worked different shifts or had recently joined the ICU team. The introductions were professional and cordial, helping to establish the personal connections that made healthcare teams function effectively. Patricia observed these interactions, beginning to understand that her error hadn't just been about one doctor. It represented a broader failure to recognize and respect the diverse leadership within the hospital. She'd made assumptions based on age, gender, and race that had no bearing on medical competence or professional authority. As the morning progressed, Samantha completed her patient rounds while Patricia continued her nursing duties. The immediate crisis had passed, but both understood that the incident would have lasting implications for their professional relationship and the broader ICU culture. During her lunch break, Patricia sought out Samantha's office on the 5th floor. She'd spent the morning thinking about their encounter and realized that a more private conversation might help address the underlying issues that had led to her mistake. "Carter," Patricia said when Samantha answered her knock, "I was wondering if I could speak with you privately about this morning's incident." Samantha invited her in, gesturing to one of the chairs across from her desk. The office was impressive but approachable, with medical journals, research papers, and surgical references filling the bookshelves. Her Harvard diploma and board certifications hung on the wall, along with photos from medical conferences and groundbreaking surgical procedures. "I wanted to apologize again," Patricia began, "but I also wanted to understand how I can do better in the future. I pride myself on being a professional nurse who puts patient care first, and I'm troubled by what happened this morning." Samantha appreciated her willingness to engage in this difficult conversation. "Patricia, I can call you Patricia, right? I think your intentions were good. You wanted to ensure that patients were receiving appropriate care from qualified physicians. That's exactly what we want from our nursing staff. But I made assumptions," Patricia interrupted. "I saw a young black woman and immediately assumed she couldn't be in a position of authority. That's not who I want to be, and it's not the kind of nurse I want to be." Samantha nodded thoughtfully. "The reality is that medicine is changing. We have more diverse leadership, younger specialists who've completed accelerated programs, and different approaches to medical training. Some of these changes can be surprising if we're not prepared for them. How do you handle these situations? Patricia asked. I imagine this isn't the first time someone has questioned your authority. Samantha was quiet for a moment, considering how much to share about her experiences. Unfortunately, you're right that this happens periodically. I've learned that most of the time, people aren't intentionally discriminatory. They're working from assumptions and expectations that may not reflect current reality. She continued. What helps is focusing on patient care rather than personal feelings. When someone questions my authority, I try to provide information calmly and then redirect the conversation toward what's best for our patients. Patricia listened intently, beginning to understand the additional challenges that Samantha faced in her role. Is there anything specific that I can do to support you and other physicians who might face similar situations? Actually, yes, Samantha replied. The most helpful thing is for experienced staff members like you to help educate newer team members about the diverse leadership in our hospital. When you introduce new nurses or students to the ICU, you could mention the different department heads, their backgrounds, and their expertise. I can definitely do that, Patricia said. Are there other ways I can help improve our team dynamics? Samantha thought about the broader implications of their conversation. I think having more informal opportunities for staff members from different shifts and departments to meet each other would be helpful. Sometimes these misunderstandings happen simply because people don't know each other personally. They discussed several ideas for improving communication and recognition among staff members, including regular team meetings, updated photo directories, and more structured introductions for new personnel. As their conversation concluded, Patricia felt that she'd gained valuable insight into both her own assumptions and the challenges faced by colleagues she hadn't previously considered. Dr. Carter, thank you for taking the time to discuss this with me. I promise that I'll do better in the future, and I'll work to help create a more inclusive environment for everyone. Samantha stood to shake her hand. I appreciate your willingness to have this conversation, Patricia. It takes courage to examine our own assumptions and commit to change. The incident between Dr. Samantha Carter and Nurse Patricia Reynolds became a catalyst for broader changes within St. Mary's ICU culture. Thompson, impressed by how both individuals had handled the situation, proposed a series of initiatives designed to improve communication and recognition among staff members from different backgrounds and experience levels. The hospital implemented monthly team meetings where department heads could introduce themselves to staff members from other shifts, creating opportunities for personal connections that prevented future misunderstandings. They also updated the ICU's orientation program to include more comprehensive information about the hospital's diverse leadership and the various pathways that brought physicians to their current role. Patricia became an advocate for inclusive practices within the nursing staff, using her experience with Samantha as a teaching tool for younger nurses who might make similar assumptions. She helped develop training scenarios that addressed unconscious bias and appropriate ways to verify credentials when questions arose. Samantha continued to excel in her role as chief of cardiothoracic surgery, but the incident reinforced her commitment to mentoring young physicians from diverse backgrounds who might face similar challenges. She began participating in medical school recruitment programs and professional development initiatives designed to support underrepresented physicians in leadership roles. 6 months after their initial confrontation, Patricia and Samantha had developed a strong professional relationship based on mutual respect and shared commitment to excellent patient care. Their collaboration became a model for how difficult situations could be transformed into opportunities for growth and improved teamwork. The ICU at St. Mary's continued to provide exceptional critical care, but with a renewed emphasis on recognizing and respecting the diverse talents and backgrounds of all team members. The lesson learned from one morning's misunderstanding had created lasting positive changes that benefited both staff and patients. For Samantha Carter, the incident served as a reminder that breaking barriers in medicine required not just exceptional skill and knowledge, but also the patience and wisdom to educate others, while maintaining focus on patient care that had brought her to her leadership position in the first place. 2 years later, what had begun as a confrontation between a nurse and a doctor had evolved into something far more significant. The Carter Protocol, named in honor of the chief of surgery, whose grace under pressure had transformed a potentially divisive incident into a learning opportunity, had become the standard for addressing bias and improving communication in healthcare settings across the region. Mary's success in creating a more inclusive ICU environment had attracted attention from other hospitals, facing similar challenges with diverse leadership and generational changes in medical practice. The hospital's training programs were being replicated at medical centers throughout the Midwest, and both Samantha and Patricia had become sought-after speakers at nursing and medical conferences. Patricia, now serving as the ICU's diversity and inclusion coordinator in addition to her nursing duties, often shared the story of her encounter with Samantha as a powerful example of how unconscious bias could affect even the most well-intentioned healthcare professional. Her willingness to acknowledge her mistake and commit to change had made her an effective advocate for examining assumptions and improving team dynamics. The incident had also led to Samantha being appointed to the hospital's board of directors, making her the youngest board member in St. Mary's history. Her leadership in transforming a challenging situation into positive organizational change had demonstrated the kind of vision and judgment that the hospital needed as it navigated an increasingly diverse healthcare landscape. Patient outcomes in the ICU had improved measurably since the implementation of the Carter Protocol, with better communication and reduced conflicts contributing to more efficient care delivery. The protocol had proven that addressing bias wasn't just morally right, it was medically beneficial, creating environments where all healthcare professionals could perform at their highest level. The lesson was clear and powerful. Respect in medicine shouldn't depend on appearance, age, or assumptions about who looks like a leader. Excellence comes in many forms, and the most skilled physicians might not match traditional expectations. True professionalism means focusing on competence and patient care rather than preconceived notions about authority. If this story moved you, remember that bias can affect anyone, anywhere, even in professional environments where we least expect. The courage to acknowledge mistakes, learn from them, and work for change can transform not just individual relationships, but entire organizational culture. Sometimes the most important conversations happen after the crisis, when people are willing to examine their assumptions and commit to doing better.